Katie Morales, and today we're going to discuss atrial fibrillation. With me in the audience today are my husband Rolando and my son Tom. Whenever I do a presentation for students, I always like to include the reading assignments, so if they have further questions, they know where to go back to in their text for more information. The next thing I like to include are the learning outcomes. As a student, I could never pick out the most important information. This way, I encourage the students to go back and see if they can meet the outcomes. For example, if they cannot identify atrial fibrillation, they would know that this is an area they need to go back to review. Then I like to include a watch and learn video. We won't do that today for the purpose of this demonstration, but I find it helps to have a short 5-minute video of a person that was diagnosed and living with atrial fib, for example, for the students to identify with. Then I like to ask review questions to establish my audience's base of knowledge. So if we don't have an audience response system, we can use something such as colored index cards, pink for A, blue for B, that type of thing. So our first question is, based on the nurse's knowledge of the disease pathology, which of the following medications is most often prescribed for a patient with atrial fib? And I bold it the most often because you will find out that all of these medications could be prescribed, perhaps, but one is most often. Then our next question is, which of the following electrolyte values requires immediate correction for a patient diagnosed with atrial fib? And we'll find out during our presentation. So hopefully, if the students don't know now, we'll do these at the end of the presentation, and they should know them at the end. Our third question, when providing discharge instructions for a patient receiving treatment for atrial fib, which of the following statements is most appropriate? Again, they could all be appropriate, but one is most appropriate. And then I like to have a blank question at the end of the presentation to ask the students what did they learn most valuable to them that day, and we'll turn that into a question. And we have to come up with 3 good distractors. So I think this really helps them learn to take NCLEX style questions and find out what makes a good distractor. So I always like to include who's at risk. And we're going to find out in the next slide, but I just like to include this overall picture of people and start the discussion, who do they think is most at risk for atrial fibrillation? Well, as we look at our next slide, we'll see the scope of the problem. I always like to know, why do I need to know this? I know NCLEX is entry-level first year of nursing. Are we really going to see atrial fib our first year of nursing? And I think we'll find out we will. It is the most common dysrhythmia. An estimated 2.66 million were diagnosed in 2010. As many as 12 million cases are expected by 2050, and the incidence does increase with age. The median age for men is 66.8 years and 74.6 for women. African Americans have atrial fib at a much lower rate than Caucasians. That kind of surprised me because we do know that African Americans are more at risk for heart disease, but yet they have much less atrial fib. And the estimated cost of treatment in 2005 was $6.65 billion. So this is definitely a big problem, and it cost us a lot of money. But if I haven't convinced you yet, let's look at the next slide. Here, you see a picture of incident of atrial fib by state. I live in Georgia, so you can see that we're pretty dark. And if you were to overlay the tax belt on top of this, you'll see that it definitely correlates. And we'll figure out why as we go along. So definitely this is something we need to know about, and we are going to see our first year of nursing. So what are our risk factors? Well, I've divided them into 2 categories, really. We have chronic renal, hepatic, or lung disease, so that could be electrolyte disturbances, hypoxia, hypovolemia, or shock, or cardiovascular disease, such as high blood pressure, obesity, diabetes, and that would include MI, pericarditis, drug use, or thyroid imbalances. It's such a big problem, there is actually a Facebook group dedicated to this. The American Heart is really trying to get the information out there for the public, and they've started, Dr. Oz has had this also, the pulse check, and they just want you to see if it's a regular beat. And if not, perhaps you're in atrial fib, and we'll find out why that's so in just a moment. So I draw this beautiful picture, an anatomically correct heart for you, to remind you that the heart, if it were heart-shaped, is divided in 4 chambers. The top 2 are the atrium, and the bottom 2 are the ventricles. The first thing we have to remember is the heart does not beat like this, like we like to think, love-dub, but it's atrium, ventricle, more like milking a cow. So our first complex is the P wave, followed by the QRS, and then the T. The P wave tells us the atrium's contracting. So just like this sponge, the atrium contracts first, empties into the ventricle. The QRS tells us the ventricle's contracting, and it releases blood out to the rest of the body. The T wave is where the heart's relaxing and getting ready to do it all over again. It's called repolarization. The positive, negative ions line up again to send that electrical stimulation through the heart to make it contract again. So just like when you go home today and you're relaxing and you think, wow, what a day. It was just such a tough day. I'm so glad to be home. And if I came in and said, hey, you'd be like, oh man, don't bother me. The heart never wants to be bothered during the T wave. It's most irritable during the T wave. So just like you, when you're having a cup of tea, you don't want to be bothered. The heart does not want to be bothered during the T wave. Very important, and we'll find out why. So this is a normal sinus rhythm. We have a P wave that tells us the atrium contract, a QRS that tells us the ventricles contracted, and the T wave where the heart's relaxing, getting ready to do it all over again. And this originated from the sinoatrial node. That's why it's called sinus rhythm. In atrial fib, where do you think the problem is? But on the QRS, if we got P, QRS, or T, where do you think the problem would be? Remember, the P was the atrium contracting, QRS the ventricle, the T repolarization. So where do you think on an EKG our problem is going to be?
P.
P wave. Okay, let's look at the next slide and see. And look, we don't have a P wave. We couldn't pick out a P wave to save our life. So if this atrium's quivering and not really contracting, how is this ventricle feeling?
Not well.
Not well. So it's not going to be able, sooner or later, will not be getting the blood it needs to send to the rest of the body. So we have a fine irregular baseline, no P wave. If you look at the next slide, our symptoms are going to be based on this problem. The ventricles aren't filling, they can't send the blood to the rest of the body. My favorite nursing diagnosis, decreased cardiac output, because the ventricle's not being filled by the atrium, it cannot fill the rest of the body. So a person in atrial fib might be asymptomatic, or they could have symptoms of decreased cardiac output, such as hypotension, fatigue, dyspnea, chest pain, or syncope. Remember syncope? Orthostatic hypotension is when you stand up and you're a little dizzy. Syncope is when you actually hit the ground. Or it could be symptoms of ineffective tissue perfusion, because if the blood's not going out, then the oxygen's not going out either, right? Blood carries oxygen. So those would be chest pains, decreased level of consciousness, or shortness of breath. I personally find a lot of patients come in and say, I just couldn't walk to my mailbox. I was too short of breath, and that's a sign that they're in atrial fib. So diagnosis and pertinent lab values include, we're going to hook the patient up to a monitor, and it could be any type. It could be EKG, Holter monitor, continuous, telemetry, whatever. But we're looking for what? What are we looking for? The P, the QRS, or the T?
The atrial fib, P.
The P wave. So we're going to look for that P wave. And then we always want a magnesium level of 2, because that's what helps the heart relax, and the potassium of 4, because that's what helps the heart contract. So I want you to think of a 2 by 4. When you think of MAGA 2, potassium of 4, 2 by 4. And we're always going to check the thyroid, because thyroid can lead to tachycardia, which would overstimulate the heart, which could cause us to go into atrial fib as well. So we're always going to correct any underlying thyroid problems. Our immediate treatment for a patient in atrial fib would be to monitor the vital signs, including the oxygen saturation, get an EKG looking for that P wave, administer oxygen and any antidysrhythmic medications, and correct any electrolyte imbalances, such as what? A MAGA 2, potassium of 4. We want that. But our immediate goal is always controlling the rate, not correcting the rhythm. So if you come into ICU where I work in atrial fib with a ventricular rate of 180, my goal is not to get you back to sinus rhythm, it's just to control your heart rate, because you are wearing yourself out trying to circulate blood that the ventricles just don't really have. Alright, so again, controlling the rate, we can use digoxin, that's a granddaddy of them all, isn't it? Calcium channel blockers, beta blockers. And then we're going to control the rhythm. And typically we use amiodarone, and we're always going to have this person on an anticoagulant. Can you guess why? If the blood's not leaving the ventricles, what's it doing?
Coagulation clot.
It's just sitting in the ventricles. And so what does blood like to do? I'm sorry, it's sitting in the atrium. The atrium's not filling the ventricles. The blood's sitting in the atrium because it's quivering. And whenever blood sits around, it likes to clot. So we have to prevent this from throwing a clot. If I get a clot in the atrium, because that blood's just sitting there, and then it finally sends it to the ventricle and the rest of the body, wherever that clot goes is where we're going to have a trouble. We're either going to have a stroke, heart attack, pulmonary emboli, or less frequently a deep vein thrombosis. But do you see why now the atrial fib overlies the stroke belt so well? Most strokes are they're ischemic due to a clot. So So, of course, this is a cardiac patient. We're going to have lifestyle changes. We need to control high blood pressure, obesity, diabetes if they have that. And our treatment can include surgical procedures such as synchronized cardioversion. So we have to synchronize it so we don't deliver the shock during the point of time that your heart was most irritable. And when was that?
Just trying to relax.
The T time. Remember, we never want to deliver shock to the heart during a T wave. It is too irritable. We could go from atrial fib into ventricular fib, which would mean we'd have no pulse. So we can do synchronized cardioversion. We can do the electrophysiology studies, and this is where they go in and try to provoke the heart to go into atrial fib, and then I say fry, they cauterize the area of the heart that's causing the trouble and just stop it, and that's the ablation. So let's look at our next slide. The cardioversion is the treatment of choice for patient, but if the duration's unknown, we're going to get that rate control, send them home on anticoagulants. Can you guess why? If I don't know how long you've been in it, what could be sitting in that atrium?
Clots.
Say it out loud, don't be
Clots.
ashamed. Clots, yes. And we'd rather that clot stay there. We're not happy you have a clot at all, but I'd like it to stay in that atrium where I know it's not causing trouble. I do not want it to go to the brain and cause a stroke or the heart to cause a heart attack. I want it to stay put. So we're going to send you home if we don't know how long you've been in atrial fib for probably 2 weeks on anticoagulation and bring you back. If it's new onset, then we'll go ahead and cardiovert you. So what do you think the biggest side effect of cardioversion is that we have to monitor our patients so closely for? If that clot's been disturbed, we need to watch for signs of stroke, heart attack, or pulmonary edema, right? Makes sense. And then our biggest risk factor will be if we don't synchronize the delivery of that shock so that we don't bother the heart during the T wave, right? We want to deliver that shock on that QRS. Let's look at our next slide. So a patient with atrial fib is going to require a lot of patient education. And so these are great areas to get test questions from, isn't it? We need to teach the patient how to assess the pulse, compliance with their prescribed medication regimen and monitoring that. So for example, if they're started on Coumadin, warfarin, which is a granddaddy anticoagulant, we need a lot of follow-up blood work to make sure we're getting them in that range we want. We have newer meds such as Xarelto, which does not require the therapy to monitor the treatment. My concern is we don't have a way to reverse Xarelto, but we can give vitamin K to reverse Coumadin. So it's just a preference of the prescriber at that point. Patients love not having to come in for lab work though. And of course, safety. They're on anticoagulants. We're going to have to worry about any kind of bleeding issue. They're on the calcium channel blocker or beta blockers. Anytime we dilate vessels, we're dropping blood pressure. We have to worry about orthostatic hypotension and falls. And then dietary restrictions. Again, the Xarelto, which is a newer anticoagulant, we don't have that because, as I said, vitamin K reverses Coumadin, but not Xarelto. So if they're on Coumadin, we have to worry about how much vitamin K are they consuming. Now, years ago, we'd tell them not to have any. Now we tell them to keep it consistent. So if they eat 3 green leafy vegetables a week, keep eating it, but always make it consistent. All right, now we're going to have a little mystery diagnosis. At this point, if we could, we'd go into the sim lab and we would put up a little case study. And I think if you go to the next slide, we actually have here it is, our 68-year-old male who complains of shortness of breath, dizziness, and feels like his heart is racing. And what do you know it is? His heart rate's 160, blood pressure 100/50, respiration's 26, oxygen stats 88 on there. So what was our first initial goal for this patient? Do you remember me saying? Control the rate, not convert the rhythm. But do you also remember that a lot of our antidysrhythmics will drop the blood pressure? Let's look where we are right now, 100/50. So this might be a little bit more of a challenge. His symptoms started abruptly earlier that day and have gotten worse. So that might mean this is new onset, which would mean we have more treatment options if we could cardiovert, correct? He has a history of long-standing hypertension, coronary artery disease. He recently had a percutaneous transluminal angioplasty, and he had 2 stents placed. So what are your initial actions? What do we want to do?
Control his heart rate.
Well, let's look first. His oxygen sat's 88, so perhaps we want to get him on a monitor. We want to get some O2 on him. Then we're going to look at controlling the heart rate. But we're going to have to balance that with dropping that blood pressure even further. So our diagnosis would be decreased cardiac output as a nurse, atrial fib as a medical diagnosis. We've talked about the treatment. And then what lab and diagnostic tests would you like to see? We'd like to see what his
Right.
mag and potassium are, and we definitely need them on an EKG, right? We need to see what his rhythm is. Looking for which complex? The P wave, because that tells us what the atrium's doing. So again, we go to the sim lab, and we could actually practice connecting the patient to a monitor and assessing pulse and heart sounds. So let's go to the next slide. We can ask the review questions again. So now, based on your earlier responses compared to now, based on the nurse's knowledge of disease pathology, which of the following medications is most often prescribed for a patient with atrial fib?
B, warfarin.
Warfarin or Coumadin, and that's because we're so worried about that clot, right? Very good. And then, based on the following electrolyte values, which one requires immediate correction? A, potassium 4.5, calcium a 9,
No.
mag of 1.8.
Yes.
Ding, 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 right? Because we wanted a mag of 2, potassium of 4. Too easy. And mag is what lets the heart just relax. All right, one more. When providing discharge instructions, which of the following statements is most appropriate? Avoid use of caffeine. That's a what? What's that going to do to the heart rate?
Increase it.
I already told you our goal is to control the rate, so that one's looking pretty good, right? Notify the physician if the heart rate exceeds 60 beats per minute. That'd be sinus, right? That's a normal rhythm between 60 to 100 beats per minute. Limit fluid intake to 1,000 mils a day. We have no evidence this person's in congestive heart failure or renal failure. Or limit cigarettes to 15 a day. That's way better than a pack a day, isn't it? But the best answer is avoid the use of caffeine, correct? All right, another tool I like to include in my teaching is a 1-minute paper. So what was the most useful thing you learned today? And what remains the muddiest point? Is there an area that you feel like you need a little bit more information on? And then let's look at the next slide. Here are my references if you'd like to go back to get some more information. And then the next slide, I'd like to ask if you have any questions, comments, or concerns. And I always provide the students a way to contact me. And I just thank you for listening to me today, and hope you learned something. Thank you.